Um, so I'm going to now welcome the public. We have a public comment period scheduled for half an hour between now and 4 p.m. I hope we can get it done in that amount of time. We are very tight. Individuals have registered in advance. So I have a list and I'm going to be reading off that list and introducing you. And if you would just take your time to comment. Now the comments will be limited to 2 minutes. We're going to cut the mics at 2 minutes. I've got to warn you. The reason is there's a large number of people that want to speak. And I will emphasize that you can always send in written information or comments to the committee's email site, tbi@nas.edu. We will look at every single comment and information will be shared with the committee. So at tbi@nas.edu. I'm going to call on you in order that I have, and if you can unmute yourself when I say your name, stay on mute otherwise, please. And I apologize again for the 2-minute cutoff. But
thank you. Hello, everybody. Thanks for having me. My name is Lynn Becker. I am a full-time caregiver for my 2 daughters with uniquely different severe traumatic brain injuries. My career previously was in clinical trial research. I did ultimately manage the TBI portal for the US government's special ops team as well. But what I would like to do is to address some very hard facts about clinical trial research in this space. Basically, there's very little research being done, which we all know about TBIs. And as a consequence, people are being left to manage this long-term chronic condition on their own with Dr. Google, which is not helping at all. We know football players are getting the limelight, but where the injuries are really occurring are in falls. And the age groups that are most affected are 0 to 4, and 60 on up. Veterans are severely affected as well too, but these are the stats. The numbers of TBI are increasing. They equate to the number of cancer cases. 1.5 million new cases each year added to 5.6 million, that's over 7 million. What do we do? Because this number is underreported by as much as 57% as reported by the CDC in their report to Congress. Since 1986, there's been 57,000 oncology clinical trials and only 1,200 TBI clinical trials. That is the injustice. The numbers are increasing in terms of funding, but it needs to move faster. These are our people's brains, our children, our spouses, our veterans. Their full potential is being taken away, not only by their injury, but by the lack of knowledge that pervades the medical community. I actually know many of the doctors in this space because of my research work. I created a platform to address the very questions about symptomology, caregiver involvement, and patient engagement. We have over 400 people and are reaching out to the veterans. I have already started to work with the Elizabeth Dole Foundation, but we can make a change through the patient input. And that's what I would like for everyone to hear. Thank you.
Thank you, Ms. Becker. That's so important. And we will be having much more conversation about research and research priorities and changes in the workshops ahead. Thank you very much for your input. And again, you're welcome to submit additional comments if you would like. Is Carrie Collins in the room?
I am. Good afternoon.
Ms. Collins, please go ahead.
Good afternoon. My name is Carrie Collins Fidel, and I'm joining you from sunny Phoenix, Arizona, where I'm the director of the Brain Injury Alliance. I would like to make brief comments on substance use disorder and brain injury. 18 months ago, through funding from Mercy Care and our state Medicaid system, Brain Injury Alliance launched a training and peer support team to look at addiction, substance misuse, treatment and recovery in the disability community, specifically the brain injury community. We networked with and offered support services to substance use disorder treatment centers, families, and individuals seeking those treatment. We found this task important because an estimated 38 to 63% of patients in treatment for SUD report a history of at least one traumatic brain injury. Pain is also the #1 reported symptom after a brain injury, and survivors may misuse their opioid medications or self-medicate with other substances, leading to a substance use disorder. Common symptoms of brain injury, such as problems with memory and inhibition, can make it difficult for a survivor to find success in recovery. Yet, we found that many recovery programs and professionals were completely unaware of this common morbidity, therefore not screening for brain injury and cognitive deficits upon intake. And they were not aware of the simple accommodations, usually very inexpensive, that a survivor may need to be successful in completing their program. We feel that remaining uninformed on the interplay between brain injury and addiction can have disastrous results, as continued misuse of substances can lead to additional brain injuries. The person is also at an increased risk for falls, vehicle accidents, and assault. Many of the professionals we work with are just beginning to understand that overdose can cause a brain injury. Many understand the need to accommodate disabilities they can see visually, like a spinal cord injury. In fact, our team felt that colleagues who worked with visible disabilities, or more commonly understood disabilities, got to start their outreach about 6 miles down the road, where our clients with brain injury seeking recovery or harm reduction were often dismissed, seen as problems, or just not wanting it bad enough. My ask today is that we not see addiction as a moral failing, but continue to explore the resources and adding treatment and screening around this cause of understanding the cause and effect relationship between brain injury and substance use disorder. Thank you.
Thank you, Ms. Collins. That sounds extremely important, and I'll encourage you to please submit any other written materials or publications, or especially research publications, that you'd like the committee to see. We will study what you send us. Thank you for raising that crucial issue. Is Ms. Katherine Snedeker, if I have saying your name right, would you, are you here? Katherine Snedeker.
Oh, Katherine, you're on mute.
Hello.
Hello.
Hi.
Welcome.
My name is Katherine Snedeker. I'm a licensed clinical social worker, and I'm also the CEO of Pink Concussions. I'm recently was the editor of Brain Injury Professional Magazine on women versus brain injury, and the nonprofit that I run, Pink Concussions. We started a domestic violence task force 2 years ago. We've had 22 meetings. We have it, I think, almost 300 members across 12 countries. And we are trying to create a connection between the TBI community and domestic violence, IPV, shelter workers, and first responders. And we created this task force because I'm seeing also through COVID that TBI people want to learn more about domestic violence, and domestic violence people are opening up to the TBI in their roles. So we need to create safe spaces where those two groups can come together with half of the piece of the puzzle and put those puzzles together. Women with brain injury and men that suffer from domestic violence, IPV, are in our shelters. They're raising children. Those children are in our schools. They proliferate through the community, and it's really important that we make those connections. I'm also very concerned, and as a white woman of privilege, the number of white representation in all these organizations, and we have a very hard trouble attracting members who are of color, and it's because they aren't represented when they look at our board and when they look at our support groups. So we're working very hard as an organization, and I am worried about the resources to the Black and Hispanic families in TBI, and especially the women that are suffering from domestic violence. So I want those communities consider when we mostly talk about sports. Thank you very much.
Thank you so much, Ms. Snedeker. I'll just speak as chair. I think we are firmly committed to digging into issues of equity of all types, and most especially for communities of color, but also for women and other groups that could be at disadvantage. So any reports you have to share with us, please do. We will take them very, very seriously.
Thank you.
I appreciate it.
Thank you for the time.
Thank you for your time. I think I have Mr. Marvin Higgins.
That's me.
Please go ahead.
Thank you, sir. As the chair said, my name is Marvin Higgins. I'm not from this country. I'm from the Bahamas, and I'm now retired. Most of my career was in journalism, newspaper world. The reason that I speak so, aside from the fact that I come from a different country, the reason I speak like I do is because I was diagnosed with TSA transitory, something to blood getting to the brain. But really what I would like to say is that I would like to speak to the researchers, people who are doing research. I would like to encourage these people, these scientists, to look at the ancient practices, yoga, where I spent a lot of my time, yoga, Chinese medicine, Kemetic medicine, and the ancient and Eastern medicines and practices, Tai Chi, Qigong, etc. And I encourage researchers and also caregivers to look into these different things, modalities, for their own good, for their own benefit. And that's all I have to say. Thank you all for listening.
Thank you,
Thank you for the
Thank you so much.
opportunity.
If you need another minute or two to get your whole message across, please feel free. But if that's what you have to say, we take it with enormous interest.
That's it.
Thank you so much. Thank you for that great reminder. You've got some champions on the committee, I know, who are very interested in all modalities that can be helpful, and I think we'll be taking
Nice.
it seriously.
Nice.
I believe that we now have Ms. Hunter Marston back with us, and hopefully problems, communication, connection solved there. Are you there, Ms. Hunter Marston?
Oh, Miss Hunter Marston, you're muted. I'm sorry, you just need to unmute.
Yes, I'm here, and thank you for having me back. I'll start right away,
Thank you.
so as not to take up too much.
Yeah,
No?
don't feel rushed. We have a little extra time, and I know that things have been challenging, so just take a breath, and we're delighted that you're connected now.
Thank you so much. So my background is when it comes to TBI, as far as work experience, is that I've worked in ERs and ICUs and trauma units, and then now I'm in primary care and mostly actually in the maternal child and adolescent division for the California Department of Public Health. My comments will, although, be related to my personal experience of having a mild TBI, a concussion 11 years ago, March 1st, 2011. I'll talk about what happened in the ER and then finish with reminding those of the need for short-term, intermediate, and long-term care ancillary services. In the ER, the chief resident who saw me, the only thing that you could tell, and that was at a trauma center here in Northern California, the only thing that you could tell that he did was that in his write-up, he said, I was alert, I was in no pain, and I did not have loss of consciousness. He totally ignored all my presenting symptoms like vertigo, headache, dizziness, and horizontal nystagmus. When I found that out a month later in my write-up, and I spoke to the assistant director of the ER, I quote you, the assistant director said, so what do you expect me to do? And I said, I expect that the chief resident and all the residents in the ER are trained how to evaluate a patient with mild TBI. I understand that this is a major trauma center for the region. However, every patient has the right to be treated with respect and also proper care. Followed by my PCP, who had to resign because of so many complaints about her write-ups. And on my chart to this very day is that my left leg is better now, and my left leg never was injured. So that's how people get different things taken off their bodies because people have in the medical record things that don't exist. So then let's fast forward with short-term and intermediate and long-term care for people with post-concussion syndrome. BPV, and BPV, for those who don't know, is benign paroxysmal see, I can't even say it myself, a vertigo, and the need for a vestibular rehab. And also, it's important when you're looking at not only social determinants of health, but other medical conditions which may complicate a short-term to long-term care. People with hypertensive meds, with the side effects of dizziness or lightheadedness, people with allergy allergies with nasal allergies in particular that involve the maxillary and frontal sinuses. And these point to the need for appropriate and timely access to these ancillary care services. And so also some people who have pre-existing hearing loss. So this is a very complicated picture sometimes with people with mild TBI, and people can, like me, can be put on the back burner. But I'm unique in the fact that I had 4 years of medical school, withdrew, and then became a DNP, and I could advocate for myself and others. But there are other people like Megan Moore. Actually, the University of Washington was my medical school. And I want to say amen all what she was talking about, the disparities. But anyway, I think my 2 minutes is up, and thank you for your time.
Well, thank you for your time. You could have not made a more apt closing comment to the whole day. So many observations and experiences, and look forward to your further counsel. I do not believe there's anyone else in the waiting room. Let me just check with Katie and Bridget. Are we have all the people who wish?
That's it, Don. That's all the public commenters who have shown up.
Well, then it falls to me just to thank everyone for a marvelous workshop. I've been in many workshops in my time in the National Academy, but few, if any, have been close to as rich as this one. To me, it emphasizes the absolutely crucial role that the voices of patients and families and carers and communities need to have in the work of this committee. We need to reflect the real experiences out there and stay rooted in those. And the eloquence and generosity of the people that have brought testimony here has been, I found it quite moving. There's no way I can summarize today with any sense of completeness, but I'll mention a few of the takeaways from me so far. And this is not meant to be comprehensive, but our attention's been drawn a lot more than I ever would have thought to post-acute care and the management, the long-term management of the consequences of TBI. We'll be talking in our next workshop about the acute phase, and there's plenty to do there, but this has really increased the volume and the salience of continuity for quite the long haul. Coordination and management issues are what we've heard over and over again. We've heard a lot about mental health, psychiatric and behavioral health supports and needs, and those also are long-term. So yes, there's a dramatic and very important area of improvement of acute care and the physical elements of TBI, but we've heard a lot today about the other behavioral and sociological and mental health issues. I would say another takeaway on the positive side is that so many of our patient testifiers spoke to superb outcomes, that outcomes that were not anticipated by people that saw them at the beginning of their journeys. This has got to speak to the marvelous work of clinicians and bioscientists so far in this field. And for me, an outsider, it gives me hope that if we can do that much so far, think of how much we can do in even more time ahead. That leads to the comments we heard about giving up. We had some pretty chilling testimony from patients and family members who were telling us about people in our healthcare system who didn't think the outcomes could be better and who were losing hope when hope was warranted. And I think that's part of a larger picture of the education of our clinical staffs. And we were reminded that extending that education outside the specialty environment of trauma care is crucial, and not just in rural areas. And we heard a tremendously interesting set of ideas about rural care, but even in mainstream primary care, where the awareness of proper management of TBI and what's possible and what's long-term about it may be a lot less than it should be. The people who told us, families and patients, about their care said over and over again that follow-up was lacking. This image, I think one of our committee members asked for an image of what follow-up would be, and we heard a description of proactivity, the clinical system reaching out to the patient and the family saying, just thinking of you, how's it going? And initiating contacts in a much more continuous way. That to me will later raise questions about registries and data systems that support the clinical work to allow that proactive follow-up to occur. Patients said over and over again that key to them was listening. A number of the people who testified they knew that something was going on, but the system was not able to hear what the patient or family knew. And that's not confined to TBI. I'll tell you, in the whole world of quality, that idea of really understanding the experience of the patient and responding to it instead of being inadvertently dismissive is a crucial matter for improvement. We heard a lot about information gaps with patients and families, that people don't know what they might need to know as patients and carers in TBI. And we have I think there's an education stream here about what would be a better way to give patients and their support systems the information they need to do really, really well. And I don't have a simple answer to that. And remember, this is not about an event, it's about a lifelong process. And so that need never goes away. We've had a couple of reminders to broaden our views as to what kind of help can be brought to bear. The technical biomedicine is crucial, but we're hearing comments about alternative medicine, about practices that might not make it into the lead journals of our day, but still seem to be helpful, and we need to maintain open minds about that broader window of intervention. I'll say again, we heard a very compelling piece of testimony about rural care, and I think that's something the committee will have to take seriously. And Eric Schoonmaker's reminder that there's a kind of kindred issue here between what the military has had to deal with in austere settings and what we may have to deal in settings that don't have immediate access to the highest levels of technical care is something the committee will have to learn about and discuss, as I'm sure we will. And then last, but by no means least, are issues of equity. I think we've only begun to touch on these. We've heard issues of equity for racial equity for African Americans and Latinx and Native Americans, Alaska Natives. I want to dig much further into that in the work of this committee to understand it. But there are other axes of equity, such as the LGBTQ issues that were raised by a panelist, and really checking hard on gender issues and women's health as a component of our inquiry. That's just the beginning. I've learned so much today, and I just want to thank everyone for your time. If there's any committee member who feels compelled to say a word or two right now, we have a couple minutes, but if not, I just want to leave that possibility open. Well, thank you all. It's a privilege to work with this group. I'm not a specialist in this area, but I know I'm working with the very best on this committee, and it's a privilege to have you all with this committee and the work we'll do. Thanks again for the people that took the time to testify. We will have 3 more workshop sessions. The next one will be this Thursday. It will begin at 1 p.m. Eastern Time, Thursday, March 18th. And there we'll be discussing gaps and opportunities in TBI care from injury to the acute care phase, leading to rehab and rehabilitation. And we'll also be dealing with research opportunities that lie in that acute phase. Thank you all for your time, and my hats off to our staff. As always, they make it easy. Have a good day, everyone. Thank you.